in both long-injury or ventilator-associated pneumonia. So with these ideas, the clinicians have adopted a strategy of lung protected strategy or lung protected ventilation. So one of there lies the importance of prevention of ventilator-associated pneumonia in neonates. I think we will not waste time. Swati will start her presentation. Swati, now you can start your talk now. Thank you very much.
Right, sir. Thank you very much, sir, for the introduction. And as sir rightly pointed out, today's topic is prevention of ventilator-associated pneumonia in neonates. So far we have studied and learned many facets of neonatal ventilation. And today I'll be just telling you about what all things we can do so as to avoid infection, sepsis, and pneumonia in a fragile neonate when the baby is being ventilated. So let us start. Are my slides
do double click, make the double click.
Okay, so
yes.
Right. Okay. I'll be presenting my ventilator-associated pneumonia prevention under the following heading. First would be introduction, definition, pathophysiology of VAP, causative organisms for VAP in neonates, the risk factors for VAP, various preventive strategies which we can do, the various bundles and protocols in place which should be there in our unit so as to prevent ventilator-associated pneumonia, and the primary take-home messages which we all should carry after this presentation has been completed. So for the introduction, VAP or ventilator-associated pneumonia is the second most prevalent healthcare-associated infection in NICUs worldwide, whether it is developing world or the developed world. In fact, the incidence, as we will see, is higher in the developing countries like the low middle income countries like India, which to the tune of 16.1 to 89 incidents per 1,000 ventilator days. In case of developed countries, it is definitely less. It is around 1.4 to 7 per 1,000 ventilator days. This ventilator-associated pneumonia has been linked to increased rates of illness in the illness as in morbidity, mortality, death, hospital stay, prolonged hospital duration, and therefore increasing the hospital costs for the patient and for the administration. So how is it caused? It is caused by aspiration of secretions, which can be the oropharyngeal secretions, the colonization of the respiratory tract, and contamination of devices and medications which are used for the treatment of the hospitalized neonate. I will be elaborating further on this as I move ahead. So the definition, CDC and National Nosocomial Infection Surveillance have defined ventilator-associated pneumonia as a pneumonia which develops at least 48 hours after the initiation of mechanical ventilation. To diagnose VAP, therefore, the patient needs to exhibit a combination of clinical, X-ray or radiological, and microbiological findings. So what are they? So I'll just define CDC criteria, 2015 criteria for diagnosing ventilator-associated pneumonia. This criteria has been actually given in infants, as in less than 1 year old babies, but they have been adapted for neonatal VAP. So separate criteria for neonatal VAP as such, CDC has not given. So the 2015 criteria is continuing. So what all happens in neonatal VAP? So basically, we have increased yes, we have increased respiratory support and new chest X-ray findings. Plus, out of the 5 as listed below, any 3 of the findings should be there. Clinical findings, which includes number 1, temperature instability, hypothermia or hyperthermia, tachycardia or bradycardia, tachycardia to the tune of more than 200 per minute, bradycardia to the tune of less than 80 per minute, clinical findings of respiratory distress in the form of retractions, grunting, nasal flare, increased endotracheal tube secretions or change in the color and character of endotracheal tube secretions, and abnormal WBC count. So what are the clinical findings associated? Clinical findings associated can be, as I mentioned, fever. We can have worsening gas exchange, which is evident on the blood gas, arterial blood gas, which we do for our ventilated newborns. New onset or increasing bradycardia or tachycardia. New onset or increasing tachypnea, respiratory distress, purulent secretions. In fact, in a study, it has been seen that hypothermia and new onset tachypnea were the most common clinical features in extremely preterm neonates. Hypothermia to the tune of 79% incidence sensitivity, and new onset tachypnea 63%. What are the radiological findings?
Please mute yourself. Please mute.
What are the radiological findings which are associated with the VAP? So it can be seen as the presence of, number one, new or progressive infiltrates on the chest X-ray, as we can see over here in the right upper zone. Adhesions, fluid in the lobar fissures, which can be over here, as in the right interlobar fissures, or fluid in the pleura, which can be in the form of pleural effusion, cavitation, any pneumatocele, air bronchograms. The air bronchograms, in fact, carry a sensitivity of 58 to 63%, 83% for the diagnosis of ventilator-associated pneumonia. In some cases, a single X-ray is not sufficient. In fact, a series of X-rays is better so as to diagnose a ventilator-associated pneumonia. Isolated out of the three major criteria which I defined, clinical, radiological, and microbiological, any one will not suffice. You have to take it as a holistic view. All the three characteristics have to come into the picture. So microbiological sampling. Microbiological sampling, which we can do in adults, it is very easy. They do endoscopy and take bronchoalveolar lavage. In case of neonates, it might be definitely difficult because of the size of the ET tube, the smaller patient girth as such. So therefore, we take tracheal aspirates. But the problem of taking tracheal aspirates is we can overdiagnose ventilator-associated pneumonia, because sometimes colonization can also be seen. Colonization is the norm or the normal thing after 48 hours of intubation. So normal colonization also we can sometimes overdiagnose as ventilator-associated pneumonia. So that is a challenge, how to distinguish colonization from actual infection. And the reliability of tracheal aspirate, therefore, is very uncertain. Therefore, a combined clinical picture, chest X-ray, and microbiological assays are to be taken into consideration before diagnosing ventilator-associated pneumonia. So let us come to the pathophysiology. In this slide, basically, I will be explaining to you what are the normal acquired and the innate, basically, and the adaptive immunity in case of newborns which are there, which can fight the respiratory infections. So what do we have? We have the reactive oxygen species, we have the reactive nitrogen species, and various antimicrobial peptides and secretory IgA, which are released by the respiratory epithelial cells so as to kill the pathogens. We also have the cuboidal epithelium, and which has got cilia. And cilia is extremely important because by the mucociliary clearance of the cilia, the various pathogens can be killed. And we have goblet cells. Goblet cells are nothing but mucus secreting cells. And various pathogens are there which are trapped by the mucus which is produced by the goblet cells. Thus, the pathogens are destroyed. After this, we also have bronchial associated epithelial cells and alveolar interstitial macrophages, B and T cells, which are also actively involved in providing immunity and giving protection from the ventilator-associated pneumonia or from normal pathogens for the baby. Now, how does ventilator-associated pneumonia come into the picture? How does it happen once the ET tube is in situ? So there are two main sources by which the microorganisms can get inside the lungs. We have on the left side, as I projected, we have the endogenous source, and the right side, we have the exogenous sources of microorganism. So what are the endogenous source? So number one would be impaired natural protection clearance system, uh, definitely that would be there, because the baby, if the baby is a preterm, the baby is under sedation, and baby is sick, baby is not able to clear the secretions on his or her own, which allows increased colonization of the nasopharynx. So increased colonization of the nasopharynx, followed by the increased colonization of the oropharynx, and also the gastric fluid pool tube along the tube in the neonates. And this is also associated with increased colonization of the tracheal secretions after a period of 48 hours, as I've already mentioned. So aspiration of these colonized fluids from anywhere, whether it is the infected colonized oropharynx, the gastric fluid, the tracheal secretions, or the nasopharyngeal secretions, any aspiration of these fluids can result in pneumonia. Hematogenous source of seeding actually is very rare, which can cause pneumonia in case of neonates. What are the exogenous sources of microorganisms which we actually are responsible for giving to the babies? Number one is the infected hands of the healthcare workers. In case hand hygiene has not been carried out properly, so from the hands of the healthcare worker, when we are handling the babies during the process of suctioning, during the process of shifting the baby, handling the oropharyngeal secretions, this can happen. Also, if the ventilator circuit is badly soiled or damaged, and if we have not changed it, then this can happen. When the condensate, fluid condensate, or the condensation during the after the humidification of the air which goes in, the condensate, if it goes inside the ET tube, then that is itself a source of microorganism. And finally, biofilm of endotracheal tube. Now, what is this biofilm? Once we induce a foreign body, which is the endotracheal tube, inside the baby, after a period of 48 hours or so, we find that normal bacterial colonization or a film forms around the endotracheal tube along with the polymer matrix. And this is actually the biofilm which is there. It is adherent. It can be adherent to the animate objects or to the inanimate objects like the endotracheal tube. And because of any trauma, or because of tube, when we are pushing it down or pushing it out, or during suction, this biofilm can be dislodged and it can go inside the lungs, thus causing pneumonia. What are the risk factors which are associated with neonatal ventilator-associated pneumonia? First and foremost, definitely being prematurity, because preterm infants are actually not capable of handling infective organisms on their own, because lack of immunoglobulins, because of their prematurity, the premature airway epithelium, which cannot clear away the secretions, which has goblet cell hyperplasia, increased mucus, decreased airway clearance, reduced functioning of the cilia, and reduced granulocyte migration, and reduced neutrophilic function. So because of all these things, a preterm baby is not able to handle infections on their own. Plus, they have immature immune system, as I've already told. Increased skin permeability, skin immaturity also leads to more amount of sepsis and infection. Low birth weight is a criteria for increasing the risk factor for ventilator-associated pneumonia and sepsis in general. These are the non-modifiable risk factors. Now, what are the modifiable risk factors which we can do something about? Ventilator days. It has been seen that as the number of days of invasive mechanical ventilation increases, the frequency, the incidence of ventilator-associated pneumonia also increases. So the number of ventilator days are very important. Prolonged antibiotic use. If we are not judicious in using antibiotics, if there are prolonged antibiotic use, then what it will do is it will destroy the normal commensal bacteria which are there, which are non-pathogenic, and cause in turn proliferation of pathogenic bacteria, which can cause severe degree of infection, sepsis, and pneumonia. Now, since the baby is intubated and a feeding tube definitely is in situ for feeds of the baby, and every time what we are doing is we are, in case of neonates, we are using uncuffed tubes. So there is a high risk of aspiration of gastric contents by the normal gastroesophageal reflux. These gastric fluid can sometimes cause aspiration, and the organisms inside the gastric fluid also can lead to pneumonia. Sedation definitely can cause, because it causes the baby to be immobile, and the baby by itself, by herself or himself, cannot clear the secretions. Now, what are the causative organisms which are involved in ventilator-associated pneumonia? The most common organism, it could be gram-positive, it could be gram-negative. The most common gram-negative which has been seen are Klebsiella, Pseudomonas, and others. The most common gram-positive being Enterococci and staph species also. So, in a prospective study of extremely preterm neonates who were diagnosed with VAP, the common pathogenic organisms which were identified were Pseudomonas, Enterobacter, and Klebsiella for the gram-negative bacteria, Staph and Enterococcus for gram-positive bacteria. In fact, because of the injudicious use of antibiotics and the lack of antimicrobial stewardship, the incidence of multi-drug resistance neonatal VAP is also on the rise. And in fact, in a study in China, it was found that it was to the tune of almost 40%. Endotracheal fungal colonization, in fact, has also been found in 8.3 to 42% of intubated preterm neonates, sometimes who require antifungal for the clearance of the pneumonia because of the incidence of fungal pneumonia. Now, how do we confirm diagnosis? As per the CDC guidelines, at least one of the following must be collected to identify the causative organism for VAP. We should have a positive blood culture or a pleural fluid culture or quantitative culture from the bronchoalveolar lavage or a protected brush specimen from the endotracheal aspirate or the tracheal cultures. Now, what are actually we have moved away from ventilator associated pneumonia and we are into ventilator associated events. So, what are ventilator associated events? They are actually brought on by persistent increase or rise in ventilator settings following a period of stable, either there has been no change, or improving ventilator settings. Following a period of improving ventilator settings or stable ventilator settings, if we have a deterioration in the ventilator parameters, like in the mean airway pressure, increase in the mean requirement of mean airway pressure by 4 centimeters of water, or increase in the FiO2 requirement by a minimum of 25 points, will qualify as a ventilator associated event, and the time period which has been given is 48 hours. So now that we know what are the causative organisms, how does it actually happen, the pathophysiology behind it, so let us see how we can prevent all these things, because eventually prevention is definitely better than cure. So we have to target, it has to be a multifactorial approach. We cannot just target one point, because VAP in itself is multifactorial. So we have to target at multiple points. So for bacterial colonization of the oropharynx and the stomach, what can we do? The preventive strategies for that would be to have judicious antibiotic stewardship policy, number one, routine mouth care during care of the neonates, a very good hand hygiene by the caring hospital staff, definitely wear gloves while working with oropharyngeal and ET tube secretions, continuous providing health education to the staff who are working for the and caring for the ventilated patients, and to take care of the baby while the baby is intubated. Now, what can we do about when there is a suspected microaspiration of contaminated secretions? What we can do in that scenario is, as much as possible, try and reduce the duration of invasive mechanical ventilation. Try and be as non-invasive as possible. Reduce the times of, reduce the accidental extubation incidences which are occurring in the NICU, and reduce the rates of reintubation, reduce the length of ventilation, and suction the oropharynx whenever endotracheal tube is adjusted. Only change the ventilator circuits when it is visibly soiled, and we should drain the condensate away from the patient. The water which is collected should be collected in a water trap in the circuit. It should not go towards the endotracheal tube. And elevation of the head end of the bed in adults, around 30 to 45 degrees is taken. In neonates, 15 to 30 degrees is also good enough. And providing the inline suctioning, close suctioning, which can definitely reduce the incidence of ventilator-associated pneumonia. Now let us see all these things in detail. So strategies of prevention can be divided into general measures and specific measures. General measures can be hand hygiene, decontamination, antibiotic stewardship, proper feeding policies. Lactoferrin and probiotics are still in the experimental stage and not very specific to prevention of VAP. Specific measures like providing bundle measures, which I will be coming to later on. Endotracheal intubation, shorten the time of endotracheal intubation. Early extubation practices, as much as non-invasive ventilation as possible. A good policy of suction, first oropharyngeal suction followed by ET suction. Head end of the bed elevation by around 15 to 30 degrees. Oral hygiene by the staff. Ventilator circuit change only when it is visibly soiled, and continuous educational interventions of the staff which are handling the neonates. So what are the general measures for prevention? Hand hygiene. Now, as we all know, hand hygiene is probably the most important criteria and for prevention of any infection, any sepsis, whether it is ventilator associated pneumonia, whether it is generalized sepsis. It is probably the most important, because we, through our hands, the healthcare workers, are actually transmitting infection as we move from one baby to the other baby. So it is very important that hand hygiene is taken into cognizance and kept in mind. So it is very important, as we all know, the 5 moments of hand hygiene have to be adhered to very strictly. It has been seen in studies that has been a reduction in respiratory tract infections from 3.35 to 1.06 infections per 1,000 patient days just by hand hygiene compliance. So we can see it is very important. It itself, in isolated in itself, can reduce VAP rates by almost 38 to 40%. Now, decontamination. The transmission of pathogens is also by objects which are used for the treatment of neonates, whether it's the catheter, whether it is the tube, etc. And on the incubator, on the mattress of the radiant former, or the incubator on which the baby lies, everything is conducive to pathogen growth because of the heat and the moisture. It has also been seen that single rooms, if we nurse babies in single cabins or single rooms where there is only one baby, the risk of sepsis is definitely less as compared to if we nurse multiple babies in a single room. But that is easier said than done in a low middle income country like ours, and in a developing country like ours, where the resources are few and far between. So we have to make do with whatever best we have. The environmental contamination in hospitals is also tremendous. Therefore, improved cleaning and disinfection practices and techniques will go a long way in prevention of infection, sepsis, etc. And how can we do it? By ultraviolet rays, by pulsed xenon mechanism, or aerosolized H2O2. Fumigation practices, etc. also go a long way. Carbolization practices go a long way in doing this. Next would be antibiotic stewardship. As I have been telling you, recurrent exposure to antibiotics and indiscriminate and injudicious antibiotics, broad spectrum antibiotics, induces the destruction of the commensal or the non-pathogenic bacteria and promotion of the colonization of pathogenic bacteria. And evidence-based guidelines have shown that unnecessary antibiotic use should be stopped, and we should have rational use of antibiotics in the NICUs. And this forms a very important part of the care bundles. Now, feeding. Critically ill patients in the NICUs definitely are fed through a OG tube, through gavage feeding. So there is a high risk for gastroesophageal reflux because of the persistent gastroesophageal sphincter being kept open. So there is a high risk of aspiration of microorganisms from the stomach secretions. And what is the solution? Solution is avoiding excessive stretching of the abdomen. What we can do is giving feed over a long period of time. It has been seen in studies that people have given it over a period of 60 minutes also. Avoiding fast and rapid feeding, which can cause sudden stretching of the stomach and therefore GR. So providing feeding over a period of time, adjusting the duration and timing of feeding, and definitely proper positioning of the baby with head end elevation of 15 to 30 degree. Also been seen that GR reduces in the left lateral position. Now, probiotics, this is controversial. Probiotics are associated with reduction in the mortality and helpful in necrotizing enterocolitis. But this is a matter of great discussion now, because the amount of bacteria, what are the strains of the bacteria, how many number of bacteria need to be given in the probiotics which are beneficial, is still a matter of debate. And but definitely it improves the composition of intestinal microbiota. And right now, however, studies are still being conducted. Now, lactoferrin, same. Studies are still inconclusive. This is basically, it is found in mother's milk. It is an iron-binding glycoprotein, and what it does is it limits the access of iron for the pathogenic bacteria. What are the specific measures? Specific measures, when we must discuss about the bundle approach. What the bundle approach does is it collects a total of around 3 to 5 evidence-based practices, and once they are done together, so they lead to a synergistic effect that is much more improvement as compared to when all these individual things are done singly. So they lead to much more improvement in the care of the patients, and a far better decrease in the incidence of healthcare associated infections. In fact, the combined interventions it has been seen, can even reduce the VAP rates to almost zero. However, there have been studies since 2008, which I'll be telling you later, which have been done as a part of bundle approach. But however, as compared to adults, our studies are still few and far between. But whatever has been done, it has been shown to be extremely beneficial. So what is the aim of bundle care in the NICUs? Aim is to minimize the need of mechanical ventilation, number one, to reduce the duration of endotracheal intubation, to lessen the amount of colonized organisms in the lungs. However, bundle definitely cannot replace infection control, and additional tools definitely must be there in the continuous improvement of the services. A QI study, a quality improvement study, must persistently be carried out in the unit so as to prevent any kind of healthcare associated infection. So endotracheal intubation, suction practices, and early extubation. A word about that. So as we know, the risk of aspiration of pathogens from the oropharynx, nasopharynx, and the stomach is too much when a baby is intubated. So therefore, the risk has to be reduced by, as I have enumerated earlier, immediate intubation if the baby is immediately intubated, and after extubation, if the baby needs reintubation within the first 72 hours, then obviously it has been seen that the rates of ventilator-associated pneumonia are higher. And as I told earlier also, the increase in the duration of mechanical ventilation is a major risk factor in VAP. And if you're not suctioning the oropharyngeal secretions properly and regularly, that is also one of the important factors. So in ET suction, we should note that a closed system is better than an open, which induces much more infection as compared to a closed system. Routine use of saline, the CDC is not recommending. Why? Because of the physiological and psychological effects for the patient. Head positioning 15 to 30 degree elevation reduces microaspiration. Left lateral position lowers GR and tracheal colonization. CDC recommends ventilator circuit changing only when it is visibly soiled or it is malfunctioning, not on a routine 7 to 10 days basis as we were doing earlier. Educational intervention programs for these healthcare staff significantly lowers the ventilator-associated pneumonia rates. Therefore, sufficient training and application of VAP prevention techniques should be taught to the staff. It reduces VAP burden in the NICUs. It has been seen in a study conducted in Thailand that after the adoption of the education programs, which they were doing regularly, they have found a substantial decrease in mortality rate as well as VAP rates from 12.3% to almost 8.7%, which was significant, with the p-value being less than 0.001. Now let's come to the main part, which are the care bundles. So as I've told you, since 2008, we have been applying care bundles for the prevention of ventilator-associated pneumonia. And in all the studies, we will see, all the studies we can find that the pre-intervention rates and the post-intervention rates are significantly different. We have finding after the intervention of and application of bundle care, we are seeing that the VAP rates have significantly reduced. Now, most of the there have been some minor differences in what are the individual characteristics or individual practices which the different units have adopted, different studies have adopted for the in their bundle care approach. But most of it will include, number one, proper hand hygiene, daily assessment for the readiness of extubation, and thorough disinfection of the environment and equipment, proper oral care, and changing ventilator circuit only if it is visibly soiled, and head end elevation by around 15 degrees, and sterile management of the airways, and healthcare training. The latest study being done by Gonzalez et al. In 2021, who showed basically the VAP rates pre-intervention 11.8 episodes per 1,000 ventilator days, and post-intervention significant reduction in VAP rates of around 1.9 episodes only per 1,000 ventilator days. Even mortality rates have come down, pre-intervention 21.3% to post-intervention 13.2%. So from this itself, we can see how far we can create an effect with this bundle approach. So the common quality improvement measures and bundles used in NICUs, as I've told, VAP bundle, this is basically a diagrammatic representation of what I've just told you. So what all does the VAP bundle involve? Proper positioning, 15 to 30 degrees. Every day during rounds, assess the need for continued invasive mode of ventilation. If possible, please wean off the baby from the ventilator and extubate the baby. And we should have strict guidelines on reintubation, as to if the baby has been extubated, then when should the baby be reintubated, the proper threshold, the proper criteria, how to do it. All those things are important. Using a fresh tube during every attempt at reintubation is very important. Finally, clearing the condensate which happens in the circuit, clearing soiled or damaged or malfunctioning ventilator tubes only if required, disinfecting the equipment, proper hand hygiene is extremely important, oral hygiene which is carried out by the staff during routine oral care of the baby with proper hand hygiene and with proper gloves and proper sterile techniques. So all these things are important. So in case VAP happens, so what is the algorithm for diagnosis and management of VAP? We know that intubated neonate, if there is an increasing ventilator needs after 48 hours of intubation, along with the new chest X-ray findings, then we should immediately think of ventilator-associated pneumonia and check for the presence of at least 3 of these clinical criteria. Number 1, temperature instability, hypo or hyperthermia. Number 2, tachycardia or bradycardia. Respiratory distress, increased ET tube secretions or change in the character of secretions, and abnormal WBC count. If it is there, if yes, then we should definitely send the tracheal culture and start empiric antibiotics to target those specific organisms. After 24 to 36 hours later, we can reassess, and it can be either divided into this green, yellow, or red boxes. If it is a green box, it means that we have a negative ET tube, the tracheal culture. Normal biomarkers like CRP, a quantitative CRP, or a procalcitonin, or the newer biomarkers which have been investigated, like it's not been done right now, but presepsin, etc. Chest X-ray findings which have rapidly improved or resolved, which must have occurred due to some other causes like maybe atelectasis, collapse, etc. And the ventilation parameters have rapidly come back to the baseline. They have improved. Then basically what we need to do is we need to stop antibiotics after 48 hours. We need not continue antibiotics unnecessarily. If it is a yellow box, so we have a positive ET tube culture, and but we are still unsure, since a tracheal aspirate, whether this is a colonization versus or an infection. Persistence of chest X-ray or lab abnormalities, like any of the biomarkers being positive, or ventilator requirements are high. So in that case, we need to reassess after 72 hours for antibiotics. Continue for one more day and reassess after 24 hours. If it is red, then we definitely have evidence that yes, it is a ventilator-associated pneumonia with positive ET tube culture, which shows infection, persistence of two of these abnormal biomarkers, persistence of these two, which are abnormal biomarkers, which can be a procalcitonin or a quantitative CRP, an abnormal WBC count, basically abnormal absolute neutrophil count, abnormal chest X-ray, which definitely shows pneumonia, and ventilatory parameters, which are definitely higher than normal. In that case, we should definitely treat it for a period of 7 days minimum. So what are the outcomes of ventilator-associated pneumonia? It has been seen that ventilator-associated pneumonia, if it happens, then there are higher chance of morbidity. Apart from mortality, which is definitely high because of sepsis, there is a higher chance of morbidity also because it damages the lungs, especially the preterm lungs in a big way, causing a higher incidence of bronchopulmonary dysplasia with a relative risk ratio of almost 3.5. Apart from increased healthcare costs, longer duration of hospital stay for the patient, and we have seen that polymicrobial VAP cases, which are not confined to a single organisms, have definite worse neurological outcomes with an odds ratio to the tune of almost 3. It is 2.74. So the neurological outcome is so bad. So to conclude, I would say that there is an urgent need to increase or enhance the diagnostics of VAP in neonatal population, because as of now, we are still uncertain as to what comprises VAP in the first place. And we need to have a holistic view, a holistic management of, as I told you, the clinical picture, the radiological picture, and the microbiological assays, all to be taken in totality. There is a need to establish more sensitive and accurate diagnostic techniques and biomarkers. As I said, pre-sepsin is something which is coming into vogue these days. And VAP otherwise continues to be a significant complication in NICUs around the world, especially in the developing countries like ours. And there are variations in the prevalence of VAP across different regions, across different units, depending upon how well they are adhering to the VAP prevention bundles. Criteria for VAP diagnosis also needs to be made uniform. Why? Because the criteria for VAP in some units are different from the criteria of VAP in other units. Thereby, in case a study is being done, so uniformly we will not be able to judge or assess the incidence and prevalence of VAP in that case, because the diagnostic criteria are not uniform. That is one of the major limitation of every study which has been done for VAP, neonatal VAP till date. We should understand the pathogenesis of VAP, as I told you, is on multiple levels. It functions at multiple factors which we should target. The measures of prevention, therefore, should be also multiple and multifactorial, and multiple interventions should be done, all of them operating synergistically, thus leading to the importance of bundles of care for prevention of VAP. My take-home messages from this presentation would be that it's a very, very common occurrence in our NICUs. Prevention of VAP by the bundle care approach, specifically customized for the respective neonatal unit, is ideal. Every unit should have a specific VAP bundle. And how do we prevent VAP? Reevaluating and revisiting every decision during rounds towards VAP prevention is crucial. Whether the baby needs continued ventilation or not, whether the baby needs further antibiotics, broad spectrum antibiotics or not, whether we are doing proper hand hygiene while touching the baby or not, whether the ventilator circuits are soiled and need to be replaced or not, whether we are doing proper care for positioning and care for GR or not. Every aspect is important. Plus, I cannot emphasize enough the importance of hand hygiene and antibiotic stewardship in the NICU. This is extremely, extremely important. So I would end by telling that prevention is better than cure. And so we need to buckle up and have better sepsis prevention and VAP prevention strategies. Thank you. Sir, I'm finished, sir.
Please stop sharing. Thank you,
Yes.
thank you, Dr. Swati, for nice deliberation, beautiful deliberation. You have touched all the points very specifically. I'll request Dr. Bijan Shah, please summarize this topic today's topic. of Swati's lecture.
Thank you, Swati. Thank you, Swati, for the excellent presentation. What we have learned from Swati's presentation is that ventilator-associated pneumonia is not uncommon in our cities. Second important thing is what she has highlighted. Once you ventilate a baby, you should have a target to extubate the baby as early as possible. I always compare ventilation just like Oimunnu's circle. In Mahabharata, Oimunnu knew how to enter the circle, but Oimunnu did not know how to come out of the circle. So you may intubate a baby, but you should have a policy to extubate the baby as early as possible. What we have seen in our clinical practice is that if you ventilate a baby for more than 3 days or a week, this in our setting most of the time, there will always be a risk of ventilator-associated pneumonia. And once ventilator-associated pneumonia sets in our places, it is very difficult to bring the baby out of that VAP. Second important thing is that once you are ventilating a baby, feeding, one of the strategies is enteral feeding. Many a times there is a false notion amongst the clinician, a ventilated baby cannot be fed. If the baby is hemodynamically stable, definitely you can feed the baby. Fourth important thing is that antibiotic assist program, rational use of antibiotic, etc. and ET suction. Because suction is a major actually procedure. We should have a policy for endotracheal tube suction, what she has said. So, and what he has said that feeding, it is always a hand hygiene. The hand hygiene we should practice religiously if you want to prevent infection and environmental care. All these things lead to reduction in the ventilator-associated pneumonia. But I personally feel as a clinician, once you intubate a baby, it is always, you should have a policy in your mind when to extubate the baby as early as possible. I think we have got few questions from the audience. One question was that
why should saline should not be used routinely for suctioning?
Sir,
number one.
Sir, 1 minute. Boshra is telling why we should saline not be used routinely for suctioning. Shati.
Actually, sir, this is one of the, we always initially used to use saline for the secretion so that they can liquefy and we can do it faster. But the latest CDC recommendations are that saline should not be used because it causes a lot of stress on the baby, on the airways in general. That is the reason why.
How it causes stress?
And second,
CDC has mentioned it, sir. That is all.
Another important thing, whatever extra intervention you do,
sterility needs to be taken into account. Yes.
Second question was that should we use separate catheter to be used for aeropharyngeal and ET section? I think it is yes.
Separate. Yes, definitely, sir. First, oropharyngeal needs to be done with a separate tube. After that, the gloves need to be changed and a fresh tube needs to be taken, catheter needs to be taken for suctioning of the ET.
Another important point is that whenever you do ET section, at least 2 persons are required.
Yes, definitely. Definitely. It is not the job of 1 person. 2 person.
Minimum 2 person is required. One person will do the ET section, another person will assist. Third question was third question is does evidence another important thing is that whenever you do ET section, the duration should be less than 10 seconds.
Yes.
And suction should be done during the time of removal. And always you should use thumb control suction catheter.
Yes.
Many places it is not available. Does evidence support closed suction system over open suction system in prevention of VAP in neonate?
Actually, guidelines there has not been sufficient evidence. In fact, all the literature which I have reviewed has said that it is equivocal. We can use closed suction, we can use open suction, but yes, so closed suction in theory, whenever you see, obviously it diminishes your chance of recurrently opening the tube, putting another fresh catheter from outside and contaminating it. a closed suction if it's there, and you prevent further desaturations of the baby also on the ventilator if you're doing it. This baby is more stable. So theoretically, yes, but as far as the studies go, no, it is equivocal.
Another important thing is that you should not break a circuit very often,
Yes,
because breaking the circuit increases the risk of infection. That is one point to remember. Many times people are breaking the circuit, changing the tube. But that should not be done. Frequent breaking of the circuit is not advocated. Third question was that Bushra is asking how to differentiate between colonization and infection in view of positive ED tube culture.
Yes.
exactly my point. That is the reason why I have told in neonatal, when we take tracheal aspirates, it is very difficult. But what we are practicing in our unit is when it is a polymicrobial growth, when it is a multiple growth, like not a single strain of organism is growing, but multiple are growing, 3, 4 are growing, then we say it is mainly colonization and not an infection. Plus, that's why I've told you need to also take the other parameters into account, X-ray as well as clinical parameters.
Thank you, Shati. How VAP increases the risk of BPT? Hani is asking.
Because it's pneumonia ultimately damages the lung, plus oxygen toxicity, and that is the main reason why in preterm neonates, if the lungs are damaged, eventually would lead in the incidence of BPD would be higher.
Thank you, Shati. Actually, what I mean that anything which causes epithelial trauma, injury,
Yes,
that will increases the risk of BPT.
BPD.
Not BPD. The same thing, when there is infection, definitely it will injure the trauma. There is chromas metaplasia, etc.
Yes,
So
true.
that will
Anything which
increase the risk of
increases,
BPD.
yes, anything which causes inflammation per se, because of whatever causes.
Routine suctioning and VAP association.
Routine
Routinely,
suctioning
you should not do suction.
not to be advocated, no sir.
Another important thing, whenever a baby desaturates or any deterioration in mechanical ventilation, there is a tendency of the resident to do a suction, which is dangerous. You should see why there is deterioration rather than go for routine
Yes,
suction. Never do it. I
yes,
think people are practicing these things that should be
yes,
avoided.
yes.
And Ornov is asking if suspected BP have based on the increased FiO2 requirement chest X-ray, is it compulsory to send existing ET tube for culture and simultaneously re-intubate the child with a different ET tube, or we
No,
may send tracheal aspirate only?
only tracheal aspirate is more than
I
enough. It is
think
definitely not advocated to put in another ET tube and give trauma to the child once again, because as we know, fresh intubations will further increase the rates of VAP.
another important event, one intubation, what we have seen, it causes tracheal injury, sometimes tracheal stenosis and laryngeal edema. And once you extubate the baby, you find baby is not crying. So one of the important criteria of successful extubation is that as a clinician, once you extubate a baby, if the baby cries, that means you have done a good job. But unfortunately, most of our
Yes,
time in clinical practice, you won't find baby is crying or baby is requiring sweets or for a prolonged period of time. So never change the ET tube. Rather, you should never use unless it is there is lot of leak, more than 90% or 80% leak is there. Bushra is again asking, should the catheter be discarded after each suction?
ideally, yes, sir.
Ideally means it should be changed, because one suction cannot be used several
Separate.
times. You should use every time a new
Fresh
suction
catheter.
catheter.
Yes.
You are utilizing a 30 lakh cost ventilator. You should change the suction catheter. Is there any role of IV gamma globulin for prevention of VAP? Dev Kumar is asking. No role.
Not
Shati
that
is
I've
no.
seen. No, sir.
No role, no role. Do not use it and do not waste patient money and energy also, your energy. Do not invest on IV immunoglobulin. Whatever immunoglobulin is available, it should not be used. I think most of the questions Shati has answered, and it was an excellent presentation. The presentation itself is self-explanatory. So before we say goodbye or good night, just one point. Whenever you intubate, always have in your mind, extubate the baby as early as possible. Otherwise, you will be caught like Ovimandu's circle. Second important thing, hand hygiene. Third is, for ET section, at least 2 person is required. One person will do ET section, second person will assist. Suction time should not be more than 10 or 15 seconds. Suction should be done during the time of removal of the catheter. For each suction, you should use separate catheter. Suction should not be done very often, as and when necessary, it should be done. Then about one important thing Swati has highlighted, changing of the ventilator circuit. Only it is visibly soiled or it is lot of damage to the circuit, then only you change the circuit. Otherwise, routine change of the circuit is not essential. Third important thing, early enteral feed. I think one point we did not highlight, good humidification is another important criteria for prevention of VAP. If we cannot humidify gas, ultimately what she has said, there will be tenacious secretion, it will obstruct the airway, there will be inflammation, and there will be atelectasis, etc. And VAP will also set in. So whatever ventilation you do, the humidification is integral part of any ventilation. I think most of the questions have been answered by Swati. Thank you once again, Swati, for an excellent presentation. I think most of our viewers who have watched your presentation, they'll be benefited, and they should start practicing what we have taught us. Thank you very much. I think if there is no question, we can
close the session
today. Thank you, sir. Thank you very much.
Thank you. Good night, everybody.
Good night.
Thank you, sir. Good night.
Good night.
Thank you.